This presentation is about the biggest paradigm shift in the history of medicine that most physicians are not even aware is occurring, and it's the genome revolution. I'm here to help you make that transition. Let's discuss it for a few minutes. The following slides are for education and training purposes only, have not been endorsed by any company or regulatory agency, are not intended as medical advice, and should not be used to diagnose or treat any medical condition. Hi, I'm Dave Brubaker, and I want to ask you a question. If a personalized report generated from a cheek swab with zero out-of-pocket for most patients told you with 99.9% accuracy how each of your patients will respond to 160 different drugs before you even prescribe them, would that make your job easier? Adverse drug reactions, as you may know, are the fourth leading cause of death in America. There's over 106,000 deaths every year. That's the same as one full jet crashing every day. 4 or more drugs increase ADRs exponentially, and 11 or more drugs increase chances of an ADR by 98%. Now, all this is largely avoidable thanks to the Human Genome Project. As you may know, from 1990 to 2003, $3 billion was spent sequencing 3.2 billion DNA pairs. Filled 10 books at 1,000 pages each. It's a lot of information. After 13 years of assimilating all this new science, a major paradigm shift is changing the way we practice medicine. It begins with the discovery of the single nucleotide polymorphism, or SNP for short. As you know, these are the 4 nucleotides that make up a DNA strand. And as the DNA strands duplicate, 1 out of every 1,000 base pairs does not duplicate perfectly. So the CG, instead of duplicating as a CG, duplicate it as a TA. That's the single nucleotide polymorphism. It determines who has curly hair and who has straight hair. And on the inside, it determines who's a slow metabolizer and who's a rapid metabolizer. This is why the one-size-fits-all prescriptions don't work. According to the National Institute of Health, the effects of polymorphisms are prominently seen in the breakdown of medications. Depending on the gene and the polymorphism, drugs can be metabolized quickly or slowly. If a P450 enzyme metabolizes a drug slowly, the drug stays active longer and less is needed. If a drug is metabolized quickly, a higher dose might be needed. We all metabolize drugs differently. About 54% of the US population does not metabolize normally. So for every 2 patients in your exam room, 1 of them metabolizes normally, the other one does not. And on the outside, you really can't tell the difference. They're either a poor metabolizer, which means the active drug accumulates and there's a risk of toxicity. They need a lower dose or a different drug. Your intermediate metabolizers are somewhere between poor and normal, also need a lower dose or a different drug. An extensive metabolizer is another word for normal. And the rapid metabolizer has very poor efficacy. It's used up in as little as 30 minutes. No more is in the body, and it requires higher dose or a different drug. Every 100 patients in your waiting room, 46 are normal, 35 are intermediate metabolizers, 13% are poor metabolizers, and 6% are ultra-rapid metabolizers. Now, I'm in the 6%, which caused me to have a heart attack. I'll tell you about that a little later. This is right off the FDA's website. There are 209 drugs that now carry metabolizer status, telling you, based on the drug, this is just the first 14, if they are how they metabolize. And 25% of all drugs are metabolized by the CYP2D6 enzyme. And of those 25%, 10% are poor, 10% are intermediate metabolizers, and 2% are ultra-rapid metabolizers. I encourage you to become familiar with the Personalized Medicine Coalition. This was launched in 2004 with 20 members. Now, 12 years later, we have 244 members. They consist of pharmaceuticals, laboratories, universities, hospitals, insurance companies, research firms. They put out a 65-page report. I'm just going to give you a couple pages as a highlight of this report. Patients who do not benefit from the first drug given. With antidepressants, 38%. Asthma drugs, 40% do not benefit from the first drug. Diabetes, 43%. Arthritis, 50%. Alzheimer's, 70%. And cancer drugs, 75% of the patients do not benefit from the first drug given. 17,000 strokes could be prevented each year if a genetic test was used to properly dose the blood thinner warfarin. 34% reduction in chemotherapy use would occur if women with breast cancer received a genetic test of their tumor prior to treatment. That's an estimated 227,000 people who went through chemotherapy last year unnecessarily. $604 million in annual healthcare cost savings would be realized if patients with metastatic colorectal cancer received a genetic test for the KRAS gene prior to treatment. This is all on www.personalizedmedicinecoalition.org. Many ADRs result from variations in genes that cause drugs to be metabolized either faster or slower than normal. Some individuals have trouble eliminating it from their bodies, leading to overdose toxicity. Others eliminate the drug too rapidly before it had a chance to work. And finally, if these genetic variations are not considered when dosing, the consequences can range from unpleasant to fatal. There were 290 people killed yesterday from wrong prescriptions. 290 people, again, will die today, 290 people tomorrow. It's the same as one full jet crashing every day. Here's the Plavix example. A recent study showed patients with CYP2C19 variants exhibited a 2 times greater risk of a cardiovascular ischemic event during a 1-year follow-up period. Here's your normal nucleotide. It's a G. And so Plavix is metabolized by the CYP2C19 enzyme, and you have an active drug. Everything works as planned. But if you've got a polymorphism and there's an A instead of a G, there's no enzyme to metabolize Plavix. It's inactive, and you have an inactive drug. This is what happened to me. 3 years ago, I had stents put in. I was given Plavix. 2 days after I returned home from the hospital, I had a heart attack, only to find out 1 year ago when I had a test done that my CYP2C19 enzyme does not metabolize Plavix normally. So poor CYP2C19 metabolizers with acute coronary syndrome, this is on the Plavix label, and undergoing percutaneous coronary intervention treated with Plavix at recommended doses exhibit higher cardiovascular event rates than do patients with normal CYP2C19 function. At the bottom, consider alternative treatment and treatment strategies in patients identified as 2-CYP2C19 poor metabolizers. Why a new protocol? Well, Dr. Jim has decided drug X is the best choice for his patient. Drug X is metabolized by CYP2C19. Drug X's new packaging says, be extra alert to sufficient response with CYP2C19 rapid metabolizers. Consider increasing the dose by 200%. Now, Dr. Jim does not know his patient is a CYP2C19 rapid metabolizer. How should Dr. Jim proceed? Would you agree we use science to diagnose, and yet we still use archaic trial and error in prescribing? One doctor told me when he goes home at night, he says, I just hope it works. If there was a way to know in advance how a patient will metabolize a drug with 99.9% accuracy, how might that benefit your patient? This is where we come to pharmacogenetic testing, or PGX testing for short. It's come of age, it's mature, it's here, and it's being used more and more on a regular basis by physicians and hospitals alike. It compares your patient's DNA to 25 enzymes to determine how they metabolize meds based on the genes inherited from their parents. It lets you know in advance if they're a rapid metabolizer, an intermediate metabolizer, extensive metabolizer, or a poor metabolizer. It begins with a non-invasive buccal swab. The results are color-coded for ease of interpretation. On the test results, as I'll show you in a minute, it'll show up next to a drug, consider an alternative, or a normal response is expected. It'll give you another column that tells you either increase this person's dose or decrease their dose, and it will tell you by how much. And this one will tell you to proceed with caution. It's an easy to read report. It's built as requested by your peers, and it's listed by drug classifications. This is a cardiology patient, and we are saying on this particular clopidogrel Plavix, consider an alternative. They are a CYP2C19, not normal metabolizer. And then you've got a whole sheet of normal metabolizing. These drugs are just fine. These are just showing you a couple of the pages from the entire report. The report includes drug-to-drug interactions based on your patient's individual metabolism status. It's why it's called personalized medicine. And by the way, if you would like to see a full report of this, go to pgxsample.com. And at the bottom of the page, you'll see a report for a cardiology patient and one for a psychiatric patient. pgxsample.com. This is one of, I think, 2.5 pages on this particular person's report of drug-to-drug interactions. This particular patient should not have fluoxetine and carfentanil, fluoxetine or aspirin. And it tells you why, and it gives you a heads up before you even prescribe. There's also a portable report. They take it with them when they travel. Take it with them when they go to their other doctors, their other specialists. And it will let the other specialists know which drugs they may and may not have. The portable report looks something like this. And I want to introduce you to Russ Altman, MD, PhD in Medical Information Sciences from Stanford University. Russ was the FDA Commissioner's Science Board Chairman. He was on the NIH Advisory Committee as a member. Russ says, we all metabolize drugs differently. We inherit how we metabolize drugs. Physicians need genetics, education, and training. And he's been building a database at Stanford in cooperation with the FDA for physicians with hundreds of drugs and their reactions to inherited genes. It's at pharmgkb.org. This will all show up on my last page, but pharmgkb.org. If you ever listen to TED Talk, Russ has several very interesting presentations on TED Talk about this very thing. Pharmgkb.org is physician education, research and development, new discoveries, new protocols. They have metabolism status on 209 drugs. And they show the status, according to the FDA, also Europe, Japan, and Canada. Notice that the FDA now requires PGX testing on 45 drugs. Do you know which drugs they are? If not, then how can you do a PGX test before prescribing? Food for thought. Over 100 drugs now carry black box warnings concerning metabolizer status. Are you aware of which drugs they are? Let's look at 4 random samples of the FDA's new guidelines. Citalopram and escitalopram for CYP2C19 ultra-rapid metabolizers. Select an alternative drug not predominantly metabolized by CYP2C19. For CYP2C19 poor metabolizers, consider a 50% reduction of recommended starting dose and titrate to response, or select an alternative drug not predominantly metabolized by CYP2C19. Basically, it's impossible to correctly prescribe either of these 2 drugs without doing a PGX test first. Dilantin for CYP2C9 intermediate metabolizers, a 25% reduction of the recommended starting dose may be considered. For CYP2C9 poor metabolizers, consider a 50% reduction of starting dose. Fluoxamine for D6 poor metabolizers consider a 25 to 50% reduction of recommended starting dose and titrate to response, or use an alternative drug not metabolized by the CYP2D6 enzyme. Codeine. CYP2D6 ultra-rapid and poor metabolizers selected alternate analgesic. When we did a PGX test for my wife, we found that she is an ultra-rapid CYP2D6, and codeine won't work on her. I'm glad we found it out early rather than to have to go through some trial and error and endure a lot of pain until the right drug was found. But as you can see, based on this new science, writing prescriptions without first identifying metabolism status makes no sense. And this is the paradigm shift. So the FDA warnings and precautions, on the FDA website alone, there's PGX dosing info and cautions on 165 drugs. 54 of these require PGX testing prior to or immediately following prescribing. And unfortunately, the majority of physicians not only don't know this is available, but are not doing it. You can see that at pgxfda.com. And that's the purpose for this presentation. We want to alert you as to new protocols that are available to you. Don't worry, no research is required. We do all that work for you. You're going to get a report, and it's going to tell you, take your patient off of this one and this one, or decrease the dose by 50%. Take them off of simvastatin. They're an intermediate metabolizer, not good for them, or decrease it by 40 milligrams a day. Decrease, increase, caution, okay. And the report is quite extensive, easy to read, and you want to send a copy home with your patient. Now, up until now, there's not been a whole lot of danger in liability in private practice, but that is going to change rapidly. With metabolizer warnings on 165 drugs, it is bait for attorneys to initiate lawsuits on behalf of patients who suffered or died from an adverse drug reaction that could have been avoided with a PGX test. So play it safe and start testing every patient. Who's doing PGX testing? Cornell, Scripps, Mayo Clinic, Georgetown, Columbia, Harvard, Stanford, Vanderbilt, St. Jude's. I'll quote from some of these in just a few minutes. Vanderbilt now requires PGX testing on all cardio patients since added to their cardio board October 2011. It's now standard of care in many of these facilities. Just down the road from where I live is Northern Virginia Health Systems, Inova. Inova is doing PGX testing on all newborns. You can read about it at innova.org/medimap. But they will be able to treat from newborn to the day they are on their last leg, proper medication, because they know from the reports which medications they will and will not metabolize. The AMA calls the PGX the future of medicine. Vanderbilt calls it personalized medicine. Cornell, Columbia, precision prescribing. Eli Lilly calls it tailored therapeutics. Duke University, healthcare today is in a crisis, focused largely on one-size-fits-all treatments, but the solution is personalized predictive medicine. American College of Cardiology, patients who underwent PGX testing before receiving warfarin had 31% fewer hospitalizations over a 6-month period. The National Institute of Health, this advance is paving the way for sequencing each person's genome as part of standard of care, leading to a revolution in the practice of medicine. Mayo Clinic, before taking a single dose, you can now know how you're likely to respond to medication. The FDA, different patients respond differently to meds. Genetic testing offers new promise for predicting in advance who will respond to a medical therapy and who won't. St. Jude's, if you knew this genetic information is available and did not act on it, you would not be practicing good medicine. Coumadin packaging. There's a table that tells exactly how to dose based on the patient's genes. The question, how does a physician know what genes the patient inherited from their mom and dad? The answer is they must order a genetic test. It's the only way. As far as our testing facility is concerned, we've been around since 1999. We have the largest network of genomic laboratories around the world, 8 countries. Our oldest client is Yale University Hospital. We test 25 different genomes, 160 common drugs, 196 gene variations. The results are 99.9% accurate. Recently, we were rated the #1 genetics lab in the country, and that was just this year in 2016. The PGX process is simple. We're going to collect a buccal swab specimen collected from our patient, overnight the swabs to New Jersey lab in prepaid FedEx envelopes. The lab receives the sample, extracts the DNA. It generates a clear, actionable recommendation. The test results are available via lists and fax. Color copies are sent by FedEx overnight. The physician makes a follow-up appointment with the patient to review the report. So the reports are available on the lab's website. You'll be given information to be able to log in and then download that onto your patient's chart. We provide swabs, requisition forms, and prepaid overnight envelopes. You provide a list of medication and insurance cards. As far as insurance is concerned, as long as your patient has health insurance, the lab will run the test and send it to you. If their insurance chooses not to pay, we absorb the loss. No patient billing. And if a person is doing self-pay, it's $1,500, and the lab does allow you to make payment arrangements. In a hardship case, we will do the test for as low as $300. Revenues for your practice, it's about 5 minutes staff time to swab the cheek, 5 minutes to package FedEx. You got a 10-minute consultation with the patient on the results. Whatever your fees are, it'll be somewhere between $75 to $150 for the consultation. Make sure you give them their copy to keep. Accurately treating the first time creates a greater sense of trust toward the caretaker. They'll love you for it. So the question is, who should get tested? Let me ask you 2 questions. Number 1, if you were driving to an appointment and I knew a half an hour down the road a bridge was washed out, but there were no warning signs, and you would lose a whole hour going down there and back, would you want me to tell you about it or keep it a secret? Of course you'd want me to tell you about it. Well, let's ask the second question. If you knew about a free report that was available to every one of your patients that listed which drugs are good for them and which drugs may hurt them over their lifetime, would they want you to tell them about it or keep it a secret? So after seeing this presentation, you now have an obligation to tell every patient in your waiting room. Why deny them this opportunity? The only decision you really need to make is to continue operating on trial and error or choosing to operate with proven science. With trial and error, you hope the enzyme that metabolizes their drug does not involve a SNP that changes metabolism to either poor, rapid, or interacts with other drugs. And then you can order a PGX test after the event has occurred to find out what you did wrong. With proven science, you avoid any events. Follow the new FDA guidelines on 165 drugs. It's the right drug, the right dose, every patient, every time, no guessing whatsoever. Your biggest hurdle is going to be, we've never done it that way before. But there is a short learning curve. Here's what the learning curve looks like. You've been operating your business on PDR and recommendations from your drug rep, and you say, let's try this drug for a while. If it doesn't work, we'll switch to a different drug. Well, instead of doing that, from here on out, you're going to say, well, let's check your DNA report to see which drug works best with your personal genetic profile. And your goal is to have a genetic profile in every patient's chart. Why deny patient A that profile and give it to patient B? Every patient should have this profile in their chart. The question is, what would Ben Franklin do? Ben Franklin became famous for what's known as the Ben Franklin T. He would draw a T on a piece of paper, and on the left side, he would list reasons why he should proceed and go ahead. In this case, it's non-invasive, it's no out-of-pocket money, it's the right drug 100% of the time. You get immediate results, there's no trial and error. The patient and both the patient and you have peace of mind. It's a portable report, and it only needs to be done once in their lifetime. Your DNA never changes. And above all, you're avoiding lawsuits. You've got that report in their chart, you follow that report, and nothing to worry about. On the other side, Ben would say reasons not to. I can't think of any. If you can think of some reasons not to, which would be a legitimate concern of yours, please call me and let me discuss that with you. If I don't have the answer, I know where to go to get it. So getting started, I suggest collect 5 samples this week from 5 patients with different diagnostics and meds, and then evaluate for yourself. Inform all your patients about a new test available for their safety and peace of mind. Let it be their choice. Don't play God in this respect. Let it be their choice. Schedule a time for us to hold a 10-minute meeting to announce this new protocol and train your staff on the paperwork. This is a wonderful time to grow your practice. Growing any business, you simply recognize a coming wave, get out in front of it, and ride it. Well, the FDA, the AMA, the NIH all say this is inevitable. In a matter of time, all doctors, all hospitals, all practices will be doing DNA testing for every patient. The wave is rolling now. It cannot be stopped. This is what's happening. All drugs are being repackaged with dosing guidelines based on metabolism status. So far, we have 209 drugs that have been repackaged. Set yourself apart. If I were a physician, I'd be advertising my practice as we do genetic-based prescribing. Set yourself apart from everybody else. And man, it will, once people see their friends' PGX tests and they see how thorough they are, believe me, I know this from experience, they say, where can I get one of those? They go to their physician, he doesn't do it, they call you because they know you're doing it for them. Stop the craziness. There's 227,000 chemotherapy patients, 2 million hospitalizations, 106,000 deaths, 17,000 strokes, $136 billion a year, not to mention the pains and delays your patients go through with trial and error. All avoidable with a simple cheek swab. 4 case studies and then I'm finished. This is from the American Medical Association, the AMA. Number 1, case study 1. JS is a 35-year-old man who has recently been diagnosed with HIV positive. Before initiating abacavir antiretroviral therapy, his physician orders genetic testing to determine whether he carries the HLA B5701 allele. Knowing that JS would develop fever, rash, nausea, and fatigue if he carried the variant allele, so the test is confirmed that JS carries that allele. Knowing that he would likely experience a hypersensitive reaction, JS's physician will probably not include abacavir in his regimen. Case study 2, DS is a 30-year-old woman who gave birth by cesarean section 10 days ago. Her physician prescribed codeine for her post-cesarean pain. Despite taking the prescribed dose, DS experienced nausea and dizziness. She also noticed that her breastfed infant was lethargic and feeding poorly. Her physician recommended that she discontinue codeine use. Within a few days, both DS and her infant's symptoms were no longer present. Earlier genotyping of DS's CYP2D6 gene may have revealed a duplication of the CYP2D6 gene, placing her in the ultra-rapid metabolizer category. Armed with this knowledge, DS's doctor would likely have prescribed a different analgesic that would have spared DS and her infant symptoms of opioid toxicity. Case number 3, JM is a 50-year-old man who recently had an acute myocardial infarction. To prevent subsequent ischemic events, JM's physician recommends antiplatelet therapy and prescribes clopidogrel. 6 months later, JM suffers another acute MI, and his physician suspects that the patient has been non-adherent, or alternatively, that clopidogrel therapy may have been ineffective. Earlier testing of JM's CYP2C19 genotype may reveal he carries a variant that dismisses the antiplatelet effect of clopidogrel. If this had been done, alternative antiplatelet therapies would have been considered, reducing the chance of JM would suffer a second cardiac event. And for me, this is my story with my first cardiac event. The last case study, ML, is a 65-year-old woman who has recently been diagnosed with atrial fibrillation. To reduce the risk of stroke and other thrombotic events, ML's physician recommends warfarin therapy. To estimate the initial dose, ML's clinical characteristics, age, sex, weight, diet were considered. However, ML will need to return to the clinic every day for INR monitoring until a stable dose is determined, and then every few weeks thereafter for maintenance. Determining ML's CYP2C9 and VKOR-C1 genotype would reveal whether she carries any variations before initiating therapy allows for more accurate initial dosing, faster INR stabilization, and less monitoring, and can reduce the risk of bleeding or clotting events. These are some of the websites I would recommend to you, and they are on the website where you found this webinar. I encourage you to visit some of these sites. We have posters for your office, a life-saving test, pharmacogenetic PGX testing, a simple 2-minute Q-tip test can determine what medications work best for you. Don't play Russian roulette with your life. Pharmacogenetic testing, a simple 2-minute Q-tip test can determine what medications work best for you. Thank you for your attention, and I appreciate your interest in learning more about this. Please give me a call, and I'll be glad to do a free consultation and discuss this with you further.